Okay, welcome everyone. So happy to have you all here, and even sorry, but more excited to have an amazing lineup of panelists here that are taking their time to help all of you dig more into occupational therapy and mental health, because we get tons of questions about therapists that want to open their private practice focusing on mental health, and just what people can and cannot do. So I'm super excited about this webinar and all of these amazing people that are here to help us learn more about OT's role in mental health. So for those of you that do not know me, my name is Kara Welke. I am an occupational therapist and have been for over 20 years. I'm the creator of the Next Level Occupational Therapy platform. And I am not an expert in this area, but I'm just here to kind of manage the questions. And all of the panelists will be the ones that will be providing us with a lot of knowledge and information tonight. So let's go ahead and have each panelist introduce themselves so we can learn more about everyone. So Ryan, do you want to go first?
Yeah, absolutely. So I am relatively new to the OT field, so seeing a lot of the OT and OTA students over there in the attendees section, so that's great. I graduated back in June of last year and started out in outpatient pediatrics, and I got my job at Mayo Clinic here working in mental health. Started this past March. Been working in inpatient, outpatient mental health since March, and also have some training now in acute care at Mayo.
Want one of us to go, Kara?
Go ahead. My internet kicked me out, so I got logged out and back in. So go ahead. Sandra, do you want to go next?
Sure, I will. Hello, my name is Sandy Ray, and I've been an occupational therapist for almost 27 years. I've worked in pediatrics and mental health primarily, and I'm currently a program director for a AOTA program in Tucson. And I also have a private mental health practice that I do as well. So I'm glad to be here.
I'll jump in. I'm Dave Merlo. I've been an occupational therapy assistant for over 35 years. I pursued a degree to become an OTA really as a means to an end because I wanted to work specifically in mental health, which is where I worked for a good number of years until I went into academia. I've had the privilege of working in mental health really during this paradigm shift of psychiatric rehabilitation, which kind of impacted a lot of the practice out there. So I received graduate training at Boston University's Center for Psychiatric Rehabilitation, and I'm also a certified psychiatric rehabilitation practitioner. And I also serve as a board director of a mental health agency in Buffalo, New York, Restoration Society, where we operate a lot of evidence-based approaches, supported employment, supported housing, housing first models. We do a lot of outreach to our homeless communities and things like that. And we provide a lot of occupation-based kinds of services. And that's what we do.
Fabulous. Who wants to go next?
I can go next. My name is Steve Nowotniak. I'm an occupational therapist since 2010. I am director of peer services at a psychiatric hospital here in Buffalo, New York, and I also set up a mental wellness coaching practice. So trying to look at it from a few different angles. I'm also a peer and work with the peer advocacy component as well.
Okay, and who's next?
I can go next. My name is Amanda Johansson, or I go by Mandy, and I have been an OT for almost 10 years, and the majority of that time has been working with inpatient and outpatient mental health and chronic pain rehabilitation, which takes a very mental health approach. And I've also been volunteering with Sandy, actually, with NBCOT, which is helping me also learn a lot about the mental health field. And I work with Ryan. She's my coworker.
That is so awesome. So I am on my phone now because my computer keeps kicking me off. So Meredith, I don't think you've gone, have you?
No, I didn't. Hi, everybody. I'm sorry. I kind of jumped in on this at the last minute. My name is Meredith McDonnell. I am a certified occupational therapy assistant. I work in a non-traditional setting. I actually work with Army service members as a civilian. So what we do a lot of different things, actually. So what we're actually, the unit that I work under is called the Warrior Transitional Battalion. It's kind of like a big unit where we have soldiers that come in who have complex medical needs and they need to get care. So what, from the OT standpoint, what happens is our OTR, she, does the start of care, she'll evaluate them and create a plan. And a lot of the plans for them include working on their goals, their own personal goals. And then myself and the other CODA, we actually run goal setting where we talk about their personal and professional goals and what they want to be able to accomplish in all areas of their life, emotional, in their physical area, family, social, spiritual. We touch on many different types of domains. Myself and the other CODA, what we also do is we run life skill groups that we create. So like her and myself and the other CODA, we've developed life skill groups that we run for the soldiers. And so right now, because of the pandemic, a lot of it is virtual. So we'll run groups kind of like on a platform like Zoom, but we use Adobe Connect. But so I've created a pain management group. I've created academic performance types groups. I just created a mental health and wellness group where I touch on sensory modulation as an intervention as a stress response intervention, and how to create, giving soldiers the skills to create their own sensory toolbox. And I've also created like a basic budgeting group where we talk about budgeting skills and things like that. So a large portion of our population is behavioral health. So a lot of our soldiers that we see are here for mental health treatment. And so they're kind of in limbo where it's kind of like, they're not sure if they're well enough to stay in the Army. So they're going to get treatment, and that could take months. And so they may get treatment and it may get better and go back, or they may not be fit enough to stay in the military, and then they got to transition out. We have to help them find ways to facilitate a successful transition.
Wow, you guys are impressive, let me tell you. So this is great. How about, okay, first of all, if anyone posted any questions previously, you'll have to post them again, because when I got booted out, it deleted everyone's chat. So if you have any questions, post them below. But we have a whole list of questions that people have turned in already. So we'll start with them. And whoever wants to take this question, if you want to raise your hand, let me know. But this is one that we get a lot. I want to start a private practice focused on mental health. How do I start? How do I know what I can and cannot do? Anyone want to take that one?
Well, I can, oh, go ahead, Steve.
No, all I was saying was that I've been looking at how to do that myself, and I don't know that I have found a clear-cut way to do occupational therapy, because what I'm finding the challenge of is whether or not insurance companies are recognizing me as a mental health practitioner, and I know that can vary state to state. So that's the reason why I just set up, and I'm starting with the mental wellness coaching practice, just to start making connections, starting to talk about trying to provide some services and explore how reimbursement, all that stuff works. But instead of sitting around trying to figure everything out first, I've just decided to do it as a coaching practice to get the ball rolling and kind of figure it out as I go.
Okay, great. Sandy, what do you have to add on that?
Well, for me, things are very different because I started my practice in Minnesota, and it's very different in Minnesota than it is in Arizona, what gets covered and what doesn't. I would recommend, first of all, when you're doing your private practice, you have to have very, very, let me put a third very on there, very good liability insurance, because you're kind of out on your own. And mental health can fall into a number of different areas for people. I work with anxiety, autism, and eating disorders, a lot of social skill groups. In Arizona, though, what I'm finding is that I do a sliding fee scale. So I don't even mess with insurance because there's so many things that are not covered. Again, it's state by state, but I'm finding where I am now in Arizona, it works better to do a sliding fee scale. And then I get referrals from therapists, from chemical dependency, from eating disorders, treatment centers. So it's a number of different places that will refer to me, but I have to do it as almost an outpatient kind of status. And I do a lot of groups because that works better for the sliding fee scale. So it just kind of depends. I would check out for sure, check out the laws of your state and find out what is covered, what isn't, because it's very different. And then again, make sure you're covered with liability insurance and just really network, because I get most of my patients from referrals. So once they get known, it works out great. It works out great. So.
Sandy, and you might have mentioned this, but how long have you been doing your own private practice?
I did my own private practice for 12 years and 12 years in Minnesota. And then I just moved to Arizona 3 years ago. So I started up about 2.5 years ago here. So total almost 14 years or so.
Okay, fabulous. We have a few questions for you after what you just said. Can you explain a sliding fee scale, and do you request a script from their MD before an evaluation and treat?
Yeah, a sliding fee scale is really based on their income. So what I do is, if they've been with a program, a chemical dependency program or an eating disorders program, a program that's already established, their MD will refer to me. So they have to have that referral to make sure I'm a good fit. Because sometimes what they need is not OT. What they need is really good, and I'm trained in DBT and CBT and motivational interviewing. However, what they may need is a psychotherapist more than they are ready for me quite yet. So the sliding fee scale, I do a group fee, and then I also do, if I'm doing individual, I do it based on their, I do it based on economics and kind of how much they make. So someone that's not making a ton of money, then I don't charge a ton of money. And there, if I was with insurance, that kind of messes it all up. So my private practice, so I'm able to kind of stay within the constraints. And then I also make sure that I do assessments on everybody that comes through. However, if the assessments have been done in their treatment center, I can use that as well.
And just to clarify, do you take any insurances whatsoever?
Not anymore. I did in Minnesota, but I don't in Arizona.
Okay. In Minnesota, you were able to, though?
Mm-hmm. I was.
Okay. Okay.
It's just a different system there.
Well, and that's just it. And that's what I hear all the time is, every state is different. And how do you figure out what you can and cannot do in your state to make sure you are doing what's right? What did you do to find that out?
Well, because I work for NDCOT, I really just used the people I knew, because they know people across the board in different states. And then I went to when I was new to Arizona, I went to the Arizona Occupational Therapy Board and the Department of Health here to find out, because I want to make sure I'm doing everything by the book and following the regulations, because I don't want to be doing a disservice to anyone. And I also want to protect my license. So I would recommend, depending on the state you're at, go to your board. They know the regulations for your state. So your occupational therapy board, as well as your Department of Health or whoever does the licensing and credentialing for your state.
Fabulous. And one, just to break it down, because you do quite a few different things, one that I hear a lot of therapists wanting to get into is like to help with anxiety. What is your thoughts on that, OT and doing a practice where they help a lot with anxiety?
I work with a therapist when we do anxiety. So although I'm trained in CBT and DBT and MI, that I feel more comfortable with a therapist at my side, because then we can kind of jointly work on it together. Because I've got a whole toolbox of sensory kinds of things that I use, and then she does more of the therapy part to it. So we work really, really well together, because I will do some mindfulness and some calming. And then I also I've had people put up swings in their houses and all kinds of different sensory things in their toolbox. But then the therapist will come and also do some of the advisement and some of the counseling as well. So it works really, really well.
I love that. And is it a psychologist or is it like a MSW when you say therapist?
Yeah, it's an LMFT that's been trained in eating disorders and anxiety. So it just kind of, you got to make sure that whoever you're working with is fully trained and licensed and credentialed in the areas that you're working with.
Well, all of this just leads to such a good point, and I don't know if anyone else agrees, but just collaborating with these other professionals and adding the value of OT to what other professionals do. I mean, I just think I love what you're doing, Sandy. That's awesome. One more question for you, Sandy. Kimberly wants to know if you use any pediatric specific assessment tools.
You know what? It's not pediatric specific, but it's used primarily in peds. I use the SPM, so I use a lot of sensory profiles and sensory profile measure, because I need to figure out what's behind possibly, let's say, anxiety or eating disorders. It could be, I mean, there's a psychiatric base, but when I'm working with teens, we got some texture things going on, and it's more feeding than it is based. I mean, it goes hand in hand. So I use the SPM and the sensory profile quite a bit. So again, they're not technically just for peds, but they're used a lot in peds, if that helps.
Awesome. Fabulous. Does anyone else have anything to add on the question? I want to start a private practice. How do I start? Anyone else have anything to add? Otherwise, I feel like Sandy did and Stephen, they did a good job with that. Okay. So next question. Do any of you have any advice for therapists on their own mental health journey for OTs that struggle with their own mental health issues? In what ways do you suggest OTs work with clients with mental health diagnoses without building compassion fatigue or burnout?
I can speak to that a little bit.
Perfect.
So I live with a bipolar condition, and so I've found that occupational therapy, the skills and tools have really helped me out with my own recovery a lot. The sensory integration is a way to kind of help self-regulate, having a structure set in place to help out with pacing out of activities and keeping a regular structure is really involved. I think one of the things with my own recovery is really looking at how do I almost like treat myself along the way and give myself permission to how do you function while feeling a little uncomfortable. So I think those are some things that are really important with doing it. I think one of the easy challenges can be to take on identifying with everybody. And so giving yourself that permission to take and do self-care along the way is really important. But I have found that the empathy of being able to relate to a person's challenge gives me the opportunity to be a better therapist along the way.
I'd like to maybe add on to some of Steve's comments, because he and I have actually had a lot of interesting discussions. But in terms of approaches. I teach our students an evidence-based practice approach called wellness recovery action planning, which actually is an approach that came out of the peer lived experience community. And the premise of wellness recovery action planning, or WRAP as it's called, is it's teaching the individual to identify their own stressors or triggers, to identify their own daily strategies that they can incorporate into their daily routines, recognizing when things are kind of getting off a little bit so that they could then resort to what we refer to as your wellness toolbox. So I actually have my students kind of do that on themselves so that they can kind of get a sense of, the underlying principles of this. It really focuses on teaching mindfulness and self-awareness. Because I think when you talk about the role of OT in mental health, I think it's helpful to distinguish between this concept of treatment or symptom mitigation versus rehabilitation and recovery, which is really focusing on helping people to develop skills and strategies. And when we think of OT and mental health, I think we lean a little bit more towards this idea of rehabilitation, really, and recovery, teaching people or, helping people to develop these strategies to manage themselves. Whereas the treatment side, oftentimes, it's the doctor and it's oftentimes medication. It's kind of the tool of choice with regard to treatment. But this idea of wellness recovery action planning, it focuses on skills, behaviors, and self-awareness, which I think those are things that OT practitioners are really good at. That's our toolbox, And so that's my thought. And Steve, you probably should bounce right back in and say more.
Yeah, there's a big difference between symptom management and symptom management is one thing, but learning to live with the condition and have a fulfilling life is something different. And focusing on symptom management can be kind of like a hamster wheel. But when we're focusing, like as an occupational therapist, what are those meaningful activities and how do we support people in being functional with them? Because I'll be honest, my symptoms aren't gone. My symptoms are softened with the medication, and the counseling has helped me work with some of the self-stigma and challenges with having a condition. But really, at the end of the day, it's how do you do the things that are meaningful and valuable for you? And the occupational therapy techniques, I think, is really what gives that skill set.
Meredith, do you want to chime in?
Yes, I really liked what both Dave and Stephen just said, because actually it's part of my wellness group that I developed. I do actually, I actually present the Wellness Recovery Action Plan to my soldiers, and I actually do. It's a big, if you guys are familiar with it, is very big. There's a lot of sections and parts to it. But I like to kind of take one or two sections to focus on with them and have them fill it out. And it's true, like they've mentioned that it brings awareness to some of their triggers or some of the warning signs that they didn't know about, in terms of their own mental health. And I think what Dave had said when he said that he actually had his students fill it out, I think that's fantastic. I think that is great because myself, I actually struggle very much so with anxiety and depression, and I actually do struggle with mental health, and I have for years. And it's actually one of the reasons why I wanted to be a provider of some kind. And I love what Dave and Stephen just talked about when they differentiated between what an OT does versus what an MD or a nurse practitioner might do, because we're not looking to to fix the problem. We're looking to give them skills to help manage, because you're right. Like, a lot of us live with this, and it doesn't go away. You just have to find the skills to kind of get through it. You know what I mean? And I love the Wellness Recovery Action Plan, because there's a section for everything. There's a section for when you're in a crisis situation, right? There's a section for, like Dave talked about, the wellness toolbox. You've got, you know, what are your warning signs for triggers? I mean, it touches on so many different areas, and it's great. And the thing I love about it is that you can always go back and change it and make changes to it. And yeah, no, I love that. And I actually had facilitated that into part of my mental health wellness group, because I thought this is perfect for our soldiers, and they've commented on it, and there's been some positive feedback about it.
So I'm super excited to learn more about this. I mean, I think we almost need to do a full presentation, maybe more, Dave, on just this topic. And, you know, because I think there's a need for it out there, and to provide this information, because I haven't heard of it and know plenty of people and myself that, yeah, I'm excited. I'll need to dig into that. So let's touch base on the future with that. Okay, I missed a couple questions, and I think we'll go back to you, Sandy, because they were in the Facebook chat. One of them was, how do you decide when they need a psychotherapist versus you as an OT?
It really comes from the referral of the physician. I don't make those decisions. It's whatever the physician really does. The other thing is I'm super, what's the word I want to use? There's no ego involved. If I can't meet their needs, I'm very honest saying, this is what I do. This is what I treat. And so I make sure that I give it to someone else. I know what my area, my scope of practice is. So I make sure that I stay within those boundaries. And if I can't meet their needs, then I need to be giving them to someone else. So I really take my cues from the people that I'm getting the referral from the eating disorders clinics, from the chemical dependency clinics, so I take my cues from them. And I take a look also, once they've signed over, I take a look at kind of the, their progress notes and things from the past OT. So most of the people that I get have had OT, it's just they're leaving the facility, and so I carry on from where they left off. So it's really up to where I get the patients. That's all from the doctors and all the professionals that I get the referrals from.
Okay, great. And Gretchen, let us know if you have any other questions. And then Casey asked, she said, do a sensory profile. Is there a sensory need, or is this just a behavior? I'm not quite sure if there's something to add to that, but maybe she's wondering why you do a sensory profile.
Why I do a sensory profile? For sure. So if I find out that, let's say they, we have an eating disorders clinic down here. They uses horses and uses pet therapy and uses some of that kind of animal therapy. And so when they leave, they don't have those things, but they're finding that they really like hugging things. And so what, if I'm finding that it's something that they need deep pressure and things, that's why I kind of do it. So I take the links of whatever they've been doing in their preceding facility and kind of figure out how can I make their toolbox, again, a sensory toolbox for them at home, because they don't have horses at home or they don't have a dog. So I really take a look at what that need is. It might be just a weighted blanket because they like the feeling of, you know, something on top of them or holding on to something. So it's really just finding where those holes are that I can provide the skills for them, and they can be their own advocates. I'm feeling stressed. I don't have a horse here, but I do have my weighted blanket that Sandy has already practiced with me. So that's really what I'm doing with the sensory profiles, kind of just making the link of what they had in their previous facilities and making sure that they're advocates for themselves and finding what they need to have kind of calming or whatever it is that their needs are. I hope that answers your question. I wasn't quite sure what she meant with the behavior. I'm sorry, Dave?
Yep.
No, I was just, you know, as I listen to you, Sandra, it just brings to mind, because I think a lot of, and I don't know if this is the whole direction of this discussion, but you know, some of the issues we have out there is finding OT's place in mental health. And sometimes as OT practitioners, we don't realize how we talk and what's unique about the way we talk and think. But we do think in very unique ways. And just in you describing, you know, the sensory profile and skills and strategies, that's where our heads are at as OT practitioners. Whereas a psychotherapist is looking at kind of, you know, what's wrong with you? What are some of the underlying problems? You're not talking about problems and symptoms and this and that. Your language is around strategies and tricks and things that you can do. And, you know, so there's, and I think, because somebody asked the question, how do you define OT? It's so easy to define PT. I think it's one of the struggles that we have in mental health practice. I really believe that, you know, this push that we've been seeing in the last 20, 25 years in, you know, psychiatric rehabilitation, recovery model, wellness self-management, a lot of that is so congruent with OT. We have such unique skills and knowledge and to offer that it's important for us to really articulate that. So I'm just only really pointing that out because, Sandra, you're speaking like an OT practitioner, and we all have to recognize that we think and speak in a very distinct manner, and we have to really start thinking about how can we promote that within mental health, because the models that are being used out there are very congruent with OT. And so that can be an opportunity for us, or it can be a threat to us, because a lot of other disciplines are doing a lot of stuff that are OT-ish, and not even disciplines, just, you know, especially in community mental health, these agencies hire people with a bachelor's degree in almost anything to do that. And we really have to become a little bit more clear and crisp in what we say, because we need to deliver the message, especially in community mental health. I know that OT practitioners really bring an extra level of polish and expertise in some of the things that we do. We should not be referring to ourselves as generalists. We are experts. We are experts in occupations. We break down occupations and understand how to break those down into the parts and pieces so that we can adapt them and things like that. We are experts in roles and routines, and we are very good at helping people to develop strategies that they can integrate into their daily routines to support their occupations, to support their roles, and to support their daily wellness. And we have to start speaking a language that I think is more marketable, if you will.
I love everything you said, David. How do we do this? I mean, how do we get more people to understand and do this? Just, I mean, here's part of my problem, and this has nothing to do with the mental health and OT world, but even in the physical health setting, I see occupational therapists struggling to identify what they do versus PTs in that setting. And I see in some settings, sorry to offend some people, physical therapists that are better occupational therapists than the occupational therapists are in that setting. But how do we get back to our roots and really focusing on occupation and learning to talk like this and be clear and communicate? I mean, how do we do it?
It's interesting. I had a conversation with an OT doctoral student last night who's out on a level 2 experience now. And what he told me was that he felt extremely prepared when he went out and his level 2 placement in a physical disability setting. He said that he was so well prepared, he was beyond prepared. He was, you know, he really got it. But when he was placed in a mental health setting, he was like reaching for straws and didn't know what tools to use in a mental health setting. And in part, as we talked, you know, the academic preparation he had. He was not taught by OTs who are experts in working in mental health settings, because we don't have many of them that are doing that. You know, and I just talked about, you know, recovery model, psychiatric rehabilitation, wellness model, what is it, the trans-theoretical model of change, and these common models that are these other disciplines who are working in mental health, they're familiar with those. And I'm seeing that a lot of OT practitioners and students are not as familiar with those models. We are not going to just all of a sudden come in with our own models and push our way into mental health. That's not going to happen. We have to know those models that are being used, align ourselves with those models so that we could speak the language of those other practitioners, because working in mental health is transdisciplinary. It's not multidisciplinary, it's transdisciplinary, meaning that there's a lot of blurring between all the disciplines. We have to be comfortable with that. We have to be able to maintain our distinct identity when we do that, but we also have to be able to blend in. I would recommend, there's an excellent document from AOTA that they put out a while ago, and the title of it is Specialized Knowledge and Skills in Mental Health Promotion, Prevention, and Intervention in OT Practice. It's a very good document because there's 2 tables in that document. One table lists all of the skills and knowledge that we as OT practitioners share with the other disciplines. And then the second table lists a comprehensive list of skills and knowledge that are distinct, that we bring to mental health and add to it. So I refer back to Sandra talking about using the occupational profile. They don't get that. They don't know that. That's our expertise. And you bring in an understanding of sensory processing and sensory profiles, combine that with, for example, the wellness recovery model. You are now teaching that client to be much more aware of their own sensory processing and their sensory profile. That's going to help that client then be much more competent in developing their own wellness strategies to support their own daily wellness. That's something that we could offer that's unique. And so we got to become a little bit more adept at combining our knowledge of sensory processing, cognition, our OT practice framework even, and using that in a more expert manner, and do it confidently and boldly. Because it's really remarkable stuff that we have.
Sorry, I'm talking and have myself muted. That's awesome, Dave. And I'm looking at the chat section, and a lot of people talk about, it comes from the OT curriculum and so forth. But like Dave said, there's also, that's not in every OT school's curriculum. I mean, like Dave, we need you to live stream into all of these different OT programs that don't have the ability to have that education. So,
but they can only give us the basics anyhow. I mean, our curriculums are so packed. I think if people want to work in mental health, go get another certification that's complementary to what you're doing. Do some continuing education in those models out there. I mean, because really they just barely can give us enough anyhow because our curriculums are so packed.
Oh, I know. Trying to fit everything in was a nightmare. Dave, could you tell the title again of that article on AOTA's website?
You guys talk, I'm typing.
Okay. Okay. Any other topics on this, or anyone else have anything to say? Otherwise, we'll kind of, yep.
Can I quickly, Ryan, you said you graduated just a couple years ago, correct?
Yep, just this past June. Mm-hmm.
Okay, so you're a fairly new grad, but you ended up in mental health. So I'm wondering how your journey led you there, because as Dave is talking about, you know, new people coming into the field, and he's right, because I'm in academia too, and FizDiz, they know exactly what that is, but I'm just wondering kind of a little bit, and you don't have to go too deep, but I'm just wondering how you landed in mental health as a fairly new grad.
Right. And I think definitely being a non-traditional student played a role in that. So I have a pretty significant background in both the military and in other areas of business prior to going back to school to get my master's. And so definitely, you know, with my experience working with service members, both active duty, reservists, and veterans, that was really a main push for me to want to work in mental health. And one of my field work opportunities as a student was at the VA Medical Center in inpatient psychiatry. And so that just really gave me my initial flavor for it. And I think that really snowballed to saying, you know, this is definitely an area that I want to be in. And I think just having a little bit of a different experience and maybe being a little older kind of helps to be able to be effective in that setting and have the confidence to use myself in various ways as a therapeutic tool and not to be so heavily reliant on what I did or didn't get in the academic setting. Because I think it's one of those where, you know, you'll definitely learn things along the way. Like I sure hope to be a better therapist 5 years from now than I am today. And I told Mandy before, I was like, you know, hopefully I can call these people back so they can get their money back for, you know, my first year. But no, I just absolutely loved every minute of it. And, you know, when it comes to just what you can really delve into when it comes to our scope of practice in the mental health setting, it's just amazing. I mean, it's really almost boundless. So, yep.
Okay, thank you. We have a question. You mentioned RAP. What would be some other good training specializations to look at pursuing as a new graduate? And I was going to ask that too, because Dave, you mentioned, you know, going on and getting some good trainings. What others would you guys recommend?
I think some of the specializations or certifications might vary by state. Like in New York State, we have CASAC, chemical abuse. What is it? Steve, do you remember what CASAC is?
No, I don't.
Substance abuse or something like that, alcohol and substance abuse counseling thing, which is, I've suggested people do that because it's a fairly brief training. I think it's, you know, you can do it within a year and you can become licensed or credentialed where you can actually bill for services with that specialty. Nationally, I would highly suggest the Certified Psychiatric Rehabilitation Practitioner credential. Number of years ago, a lot of OTs in particular pursued that. There's a national association, the Psychiatric Rehabilitation Association, which is an interdisciplinary organization. It's also made up of people with lived experiences. And for a number of years, that organization was pretty big. It's gotten smaller over the years, I think, just because of, I don't know what, you know, mental health is you don't make a lot of money in mental health, but they administer that Certified Psych Rehab Practitioner credential, and that's not too difficult to get. You have to get, and people who graduate from OT and OTA programs meet some of the academic requirements for that, and then you have to work for so many months within a mental health setting, and then you study for an exam and you get that. There's only a few states that recognize that in terms of employability, but I would not just pursue those specialty certifications just because it qualifies you for a specific job. I would do it because it adds to your marketability, your credibility as a practitioner. I would also encourage anybody to affiliate outside of the OT community. We tend to be sometimes insular within our community. And if you're interested in working in mental health is, like I said earlier, it's transdisciplinary. We blur all over the place, and you have to be comfortable with that, and you have to network with people of other disciplines. And there's a lot of sharing back and forth between your practice expertise and things like that. So you just got to get comfortable doing that.
For me, I remember I wanted to be specialized, and I wanted all these credentials. I didn't have any money when I graduated. So what I did do, or I had to do, was CEUs. So I tried to direct my CEUs towards area of interest, and that's how I got into some DBT and CBT and motivational interviewing. And there's a fly bugging me right now. It's making me a little, I'm in the warm, so you guys are freezing up there, but I still have flies, so not good. But yeah, I tried to do my CEUs in the direction that I wanted to be helping. So I did some animal assisted therapy and just tried to do that because those were tending to be a little bit cheaper. And then as I got more established in programs and was making a little bit of money, then I could do some credentialing. But for me, I just didn't have a ton of money when I was out of grad school. So I just tried to do some CEUs and some area of interest. And that's how I actually learned about RAP in Minnesota, because it kind of started there. And so I did some training with that. So I think Dave's absolutely right. Try to go outside of our little OT bubble. And there's so much out there that can really enhance our skills.
David, Sandra, the rest of you, is there any way that we could maybe put all of those that you just listed in a document that we could send out to people that are watching, or even post for other people that are interested?
Mm-hmm.
That would be awesome, because I know some were asking for it, and I wasn't writing. I should have been. Okay, so, because that would be a great resource. Next question. And Ryan, I don't know if you want to start with this one. How do you influence a team at a facility to collaborate, promote, and respect each client's routine?
Yeah, absolutely. I can start with this one. Honestly, I think that regardless of how long you've been with an organization, or you've been at a company, it's important to know that no matter what your title is or where you stand, you still have an opportunity to influence and to make a positive difference. And I think one of the ways that is most impactful is just essentially leading by example, and just being able to have those honest conversations with your coworkers, and just being sure that it's for the patient. It's not. I think sometimes we get very hung up on the things that we want to do in our treatment sessions, or the things that we want to accomplish, and you have to be very willing and flexible to be dynamic, and just work with the patient and where they're at and what their needs really are at that given point in time, which could be drastically different than the plan that you plan to go in and execute at that moment. And just being very aware of individual biases that we all have that are very, very normal to have, but making sure that that's not something that just is maintained within us. It's something that is talked about and shared so that we can have this idea of continual improvement, continual process improvement, or just betterment of the organization and what we're trying to offer our clients, offer our patients. So that's really, I think, where I would start with that.
Fabulous. Thank you, Ryan. Anyone else want to add on that? Add in? Oh, you know what I mean. Anyone else want to comment on that?
I forgot the question. I'm sorry.
How do you influence a team at a facility to collaborate, promote, and respect each individual client's routine? Okay, there's one that kind of talks about a setting. Mandy, if you want to take this one to start with, how do you address mental health in a setting that is primarily for physical rehab?
Yeah, so I think this question, when I was looking at it, was directed at specifically working in a SNF, but I have experience in acute care as well. And I think that a way to have other disciplines recognize kind of what OT can offer in terms of mental health is when you go to the multidisciplinary rounds and discussing if the people in rounds are discussing the patient and their needs, kind of saying, oh, OT, we can work on that skill. And I found that the more that I talk about what we can offer and how surprised the other disciplines are in rounds sometimes about what we can offer, then they I think then they start to really see the value and see that this is an area of OT that we can provide. So essentially, speak up in multidisciplinary rounds is huge. And then they see the outcomes with the patients. I think that makes a really big difference.
Great, thank you. Does anyone else have anything on this topic?
Just an academic thing to throw in there. I think the model of human occupation, which is probably one of my favorite models, I mean, it talks about, you know, these subsystems with people and that habituation subsystem, how human beings tend to organize, you know, our daily tasks into habits and routines. And I mean, that's how we survive on a daily basis, is we routinize and we, you know, habituate, so to speak, things, so we don't have to constantly be expending so much cognitive energy on a daily basis. We just kind of follow our routines. And that's part of what sustains all of us in our mental health and well-being. And sometimes mental illness or symptoms disrupt our habituation to subsystem, our way of organizing things. And I'm saying that because it's kind of a simple way of explaining to other disciplines. So again, I think some of our models could be instrumental in helping us to communicate to other disciplines, to helping them to understand how, you know, habits and routines are important to all of us in our daily lives. And it's an opportunity really to kind of talk about, you know, our OT ways of thinking.
Kind of going, oh, go ahead. Who was going to go?
I was just going to say quickly, because I'm in academia, I talk to the nursing students, I talk to the PT students, I talk to them because I want them to know what we do when they get out to a SNF or when they get to a clinical site or a school, because they sometimes don't know what we do. They're in their little nursing bubble or their PT bubble or radiology or whatever. And I want them to know, hey, I remember her saying that this is what OT does, and kind of venture out. So then I'm teaching them. They're not in my department or my program, but I want them to know what we do when they end up being out there. So I'm always putting my fingers in there and letting them know this is what OT does. So when you're out there, make sure you're looking for us. So that's kind of just something I kind of add.
A few colleagues and I, we had written a paper a number of years ago about habits and how to change habits and things like that. And we sought to get it published not in an OT journal, but in a nursing journal, because we wanted to inform the other disciplines about, you know, the relevance of OT.
This is kind of a side. I don't even know if you guys have, let me know your thoughts. So I've seen, like, because I've been an academic fieldwork coordinator for 8 years, and we would send, you know, our students out to different sites and want them, you know, they would have different psychosocial based assignments and so forth. And they would hear from the therapist, we don't do mental health. This isn't a mental health site. but we're like, we need to be addressing the whole body, no matter what site you're in. How do we address that?
Occupational profile.
Yes, I know, but so many people
That
don't
should
even
be
know
the
about the
start.
occupational profile. Oh,
And if you read the OT practice framework, the process begins with conducting that profile with the client before you begin to evaluate what's wrong with him. And that's kind of a reverse in a lot of ways in people's minds, because that's the medical model way of thinking, is find out what's wrong with the person first and then come up with a plan. But if you talk with people in the peer recovery movement, you talk with people that understand recovery model and psychiatric rehabilitation, you always start with the individual first and what is important to you. In pure OT, that's what we're supposed to do. And that's where it should start, is with the client first and who they are, where they're at, and what they want. And that should start everything. Just the way it's supposed to be. So.
right. So I'm curious, Dave and Sandy, in your guys' programs, when you guys do level 1s and level 2s, do you have specific mental health placements and specific physical health placements, or are your just placements and your students focus on kind of everything at those placements? How is your program set up?
You want to go first, Dave?
You go first.
For me, level 1 gives you a little bit more flexibility. So they don't necessarily have to have a mental health OT overseeing. Someone has to be there, watching everything. So they have to have kind of a supervisor. But we can go into, we go to homeless shelters, we go to community. And again, we're taking, and I liked what Ryan had said, it's not our agendas as OTs, it's and Dave said this too, what do the clients need and what is their goal? So our level 1s, we get a little inventive, I would say. They're really good places that people are going through things, and I have them take a look at what's the OT role in that homeless shelter? What's the OT role in a number of community places? So we don't technically, especially level 1, we have more flexibility there than we do for level 2. But we kind of just check different things out. And it's much harder right now for placements with COVID going on. But that's kind of what we take a look at. So I don't know how you guys do it, Dave, but.
There was a time years ago when we had the luxury of those sites, pure, mental health service sites, where we would always require that our students do one mental health somewhere along the line, whether it be a level 1 or a level 2. We've gotten away from that because there's just not those particular sites. So ACODE standards dictate that you have to have at least one focusing on mental health or psychosocial aspects of occupation. I have some wording around that. So again, we use the occupational profile as kind of our big project that the student has to do, typically on a level 1 experience. That's primarily to satisfy the accreditation requirements. But we really focus on that more. The students are focusing on developing an occupational profile, focusing on their therapeutic use of self. And then I forgot else what we're doing. I feel embarrassed because my field work coordinator has kind of taken over that, and she's doing a great job with that. But we no longer require that you have to be in a mental health setting because there's just not those places out there, unfortunately.
And that's how our program was too. Back in the day, they did have the luxury of having a mental health and then a physical health, but we, just with the lack of sites, we went away and we had assignments that really focused on meeting the ACODE standards and focusing on the mental health. It's just that we got a lot of pushback from sites and therapists being like, we don't do mental health, we're just physical health. And it's like, it's involved in everything we do. I guess I could say I'm primarily physical health, but that's not even true. Most of my clients have something, whether it's dementia, depression, anxiety, and the list goes on. So just really integrating those things together. Okay, well, moving on, community-based mental health. We have some questions on this. What do you see as future best practice opportunities for community-based mental health? Anyone want to take this?
Best practice or future opportunities?
Well, we can talk about either. It says future best practice opportunities, but maybe let's just talk about what are best practice opportunities, or what are even just opportunities for OTs and community-based mental health.
Can I take a stab at that to start out?
Yep.
And I saw a question earlier, you know, I don't see many jobs for OT practitioners in mental health. You're not going to find job listings that say occupational therapist or occupational therapy assistant. You're going to be looking for, you got to read between the lines. You just have to. And this is where I think occupational therapy assistants have a better chance at making it mental health. And you OTs out there can yell at me, but the reason is mental health does not pay as much as other areas of practice. Okay, AOT just published their salary survey just today, actually, and you know, mental health is significantly lower. Community mental health agencies are not regulated in the way that they have to have an OT on staff and a licensed social worker and this and that. They're hiring people, okay, people with skills. So the people that can afford an entry-level position in mental health are going to be occupational therapy assistants, because they went to school for 2 years and they're anticipating a starting salary that's closer, you know, it's just closer to what OTAs are getting out there. So don't let that hold you back if it starts, the job starts a little bit lower, but you get a job as a job coach, residential counselor, psych rehab practitioner, skills training specialist, you know, case manager. Take those jobs, because what happens is you're really good at it because you got a lot of skills and a lot of knowledge. It's very relevant, and you're going to move up in that organization and you will become a supervisor or this or that. And that's what happens to OTAs that work in mental health and they start out in mental health. OTs are going to have a harder time to get into those jobs because of the starting salary. I wish I can convince some organizations to, you know, hire an OT. I've got some ideas. I think I have ideas in terms of how local universities can partner with nonprofits and maybe help subsidize, because if that university can get an OT employed in those community mental health agencies, then they have a steady stream for level 2 field work, and they could rely on those level 2 students as part of the workforce, and it legitimizes the role of that OT in that agency. And then maybe we can start to create some little incubators out there. But I think OTAs are going to have a much easier time if you want to work in mental health. I see on the an opportunity out there working in academia. We should get occupational therapists working in admission departments and advising, academic advising, and academic settings. There are a lot of college students who come in with mental health conditions. You add to that the fact that academia is a high stress environment. You have a lot of students that have mental health issues. Colleges need to retain students, because if they lose students, they lose tuition. So we really got to get some OTs thinking about pushing their way into student support services in academic settings. I think it would be a gold mine.
I love it. And we actually tried to get a program set up within our community college doing just that. We had written up, well, the program director had tried this years ago, and then we tried it again, but we had written up a whole plan of even integrating our students and I mean, it's just a perfect setting. I mean, we're totally needed. And
Yep.
we just saw that as, you know, students not getting what they needed on campus. But yeah, it's a great place.
Shout out to my friend Deb Battistella over at in Buffalo at Erie Community College. They're doing just that, and they're turning that exactly what you're describing into a level 2 experience for their students. And they're doing some pretty cool stuff. That's
awesome, Deb. Yeah, we should chat. And I know Sandra, yeah, I can share that plan. We, I mean, it was, I'll have to dig back and find it, but we thought it was pretty awesome. Okay, another question just popped up. What is current best practice in community-based mental health? What interventions or approaches are most commonly used?
I can speak to this just a little bit. I think that it all comes down to the occupational profile, like Dave has been saying, but interventions that other people have already mentioned are sensory and emotional regulation type things. And skills-based practice, teaching people strategies and skills of how to work towards the meaningful activities that they want to do. So, but I think that it all comes down to the occupational profile that you create, and then adding in how to manage their stress, emotions, mood, etc.
Oops, sorry. How about groups on top of that? Because I know Sandy mentioned she runs some groups, and I know Meredith had to go, but she talked about a variety of different groups. I mean, how does that, do you guys feel that has a good place in community-based mental health?
Absolutely. Groups work very well with wellness, self-management. Groups can work very well with direct skills teaching that you talked about. Groups can work very well with working with clients to identify their primary goals, you know, exploring self-awareness and what we refer to as environmental awareness, helping our clients to become more aware of the nuanced differences in various environments, whether it be work environments or academic environments, to help them to become better informed decision makers in terms of deciding what they want to do in the future. Because a lot of the states are focusing on recovery-based shared decision-making models, helping clients to decide big goals, what they want to do in terms of getting a job and things like that. So there's a lot of best practices around using shared decision-making approaches, working with our clients, to helping our clients to be better decision makers about what they want to be able to do. In terms of other best practices out there, the evidence-based approaches of supported employment, transitional employment, supported housing, housing first models, supported education models, those are all evidence-based approaches. And AOTA has a number of documents that explore those and list them. They're not our domain, but those are areas because they focus on roles and occupations and fitting in various, you know, whether it be supported employment, work environments, or supported housing. It's all fits in with our domains.
Dave, are you familiar with autonomy? And Shayna, she's from Pennsylvania, but everything you just said, that's what they strive to do within the community. Are you from?
Did you say
autonomy? Yeah, have you heard of that?
Doesn't sound familiar to me.
Okay, I'm gonna connect you two, just so, I mean, just literally because everything you just said is what they talk about all the time and what they're really working on. So I'll connect you guys. Okay, Mandy, you had this question. What assessments do you use and what outcomes are you focused on?
Yeah, so I think a lot of the assessments that we use have been mentioned throughout this discussion, but we really when I'm working in inpatient mental health units, the MoHost, which is based on the MoHo, and it's the Model of Human Occupation Screening Tool. We use that to kind of help people. It kind of addresses like volition and habituation in your environment and how that all connects. And the sensory profile, like Sandy talked about, is really helpful, especially with adolescent and pediatric population. And outpatient, we use a lot of the COPM, the Canadian Occupational Performance Measure, for not only goal setting, but measuring their progress. And I think that that's huge in mental health, is for clients to be able to actually see the changes they're making, and that their self-perception of those changes is really what matters. And so that's a personal favorite for me, because I think it makes a huge difference to the patients. And then other assessments, I mean, cognitive assessments are also huge to make sure we're grading activities and ensuring our clients are able to understand what we're working on. So in terms of that, like the cognitive performance test, the ACLS, the screens like that. And we've just recently started using the weekly calendar planning activity, WCPA, for intervention and assessment. So those are just a few, but I'm sure other people can chime in too.
Anyone else have others to add? I mean, you covered a lot of the great ones that I know of.
Yeah, it's a good list.
Okay. Maybe we could, along with that other list, maybe we could form a list of, you know, kind of your guys' top assessments that you like to use in that area. People might like to use that. So Michelle asked, does anyone use the Allen Cognitive Level Screen anymore?
I have a thought about that. And I teach it in our program. I never liked Allen from years ago because it just labeled people, and I don't like to label people. But there's been almost a resurgence in the focus on cognition. OT is really taking a, you know, that's kind of an area that we're looking at. And more recent research on severe psychiatric conditions like schizophrenia is revealing that there are cognitive underpinnings that contribute to the symptoms that people experience. So I think there's almost a resurgence maybe with this, in particular, the Allen cognitive scale, because it helps us to understand where a person is functioning. And it's some of the cognitive tools are very functional. You're engaging them in occupational, you know, tasks. So I see some use in it. And as I was saying before, how we can contribute something, especially in community mental health. None of those other disciplines know anything or much about cognition. And I could see some utility in using some of the Allen assessments in community mental health settings to kind of benchmark where a person is at, which would then enable us to determine how we need to grade down or modify lessons and group process with those individuals. And maybe to also teach some cognitive strategies, you know, cognitive remediation or cognitive, you know, compensation.
Do any of you guys use the performance assessment of self-care skills? Because I know, you know, they have that cognitive IADL domain that has like quite a few under that list. Have you guys, any of you utilized that one?
Googling it. Say it again.
So it's the evaluating occupational performance, and it's the performance assessment of self-care skills. It's called the PASS, P-A-S-S. And it's out of the University of Pittsburgh. I went to let's see, it was noon to 6:30, however long that is. At the AOTA conference in New Orleans, I went to a training session on it. And then I kind of forgot about it until my students and I were talking the other day about some good functional based assessments. And yeah, I mean, that's a good one that you guys might want to look into. You can gain access to it by visiting the University of Pittsburgh Department of Occupational Therapy website. So, and I can share that link or whatever with you guys. I just didn't know if any of you guys have heard of it or used it.
No, it looks very interesting. I just searched pass evaluation and it came right up.
Okay, awesome. Okay, I know we're getting close to an hour and a half. If any of you guys on the panel need to go ahead. We understand. If not, we'll go 11 more minutes and see. We've covered most of these questions, but I know this is a big one. What billing or reimbursement considerations are there when providing mental health services? And I know Sandy kind of touched on it, and that's why she's doing like the private, like the not through insurance, but does anyone have any thoughts on this?
I can go back to when I worked at Melrose Institute, which is an eating disorders facility. We were part of a blanket package. So you got OT, you got rec therapy or art therapy. So it was all under their package, so to speak. And package makes it sound really attractive, but I mean, it was costly, but every patient got OT, art therapy, whatever. So there, it didn't really apply because it wasn't a separate entity. So I don't know if you guys at Mayo have it where you have OT as something separate, but we had it as part of our package. And package isn't the right word, but it was like a grouping of therapy that everybody got. So that.
So at Mayo, we are separate. We aren't part of kind of the package of if you're in the hospital, you would get OT. It's kind of like a consult service. And because Mayo is so big, we don't really see the behind the scenes of the billing and the insurance type stuff. Yeah.
And David, you might be able to speak to this, but I know when students would go out to different mental health sites, most of them were part of like the package type system. It wasn't therapist billing for individual OT services is what I would say almost 100% of them were, but.
Yeah, exactly.
Okay, Stephen. Some states recognize OTs as qualified mental health practitioners. Do you see value in this? How can I leverage this in my scope of practice?
I know that some states, I was just looking at a sheet from AOT on that, and it was saying that there's a lot of states that don't recognize OT as a qualified mental health practitioner or don't have it listed as that special thing, which I know sometimes makes it difficult to access with reimbursements and things. I do think that would be an area that the profession, if they can make some kind of headway with that, I think that could open up a lot to be able to have that qualification. But when I was looking at this, I really wasn't seeing a whole lot of that available.
I think it would help to distinguish OT within mental health as part of the gang. I've seen so many over the years attempts to really achieve this, and it's not something that's done nationally. It's done by state. The challenge is, again, there are so few OT practitioners who align themselves with, mental health practice, that there's not enough people to really get out there and really campaign to their states to get that pushed through. I did see in New York, and I've actually been thinking about it, one OT academic program took it on, actually Cayuga College in Finger Lakes of New York State area. And I thought that was a pretty remarkable idea, because you're using the energy and the brain power of graduate students to really work towards that, to campaign for that. And because I don't know what the state associations are capable of doing around that, because they're so spread out doing so many different things. So maybe if we pool together some of the energy within academic programs, because gosh, it would be such an awesome learning experience in terms of advocacy for students to take on. That would be awesome. I'm not sure what would happen if all of a sudden OT was recognized as a QMHP. I don't know what that, I'm not sure what it means. In terms of working in my sector of community mental health, where we're not delivering regulated services like our state community mental health system, like our like comparable to day treatment programs, they have their own set of regulations in terms of who works there. And I'm not sure if being a QMHP would automatically include OT as one of the required disciplines to be working in those settings. I don't know enough about that. I think it would be a good thing, and anybody from a graduate program out there, maybe it's a good project to work on.
Well, and now is the time to really look at all of that, because we need to come up with creative fieldwork options for all of these students that are stuck with not being able to take fieldwork. Like I have two awesome OTA students with me right now. One is with me in person, and the other one is in Kansas City, Missouri, which is not close to North Dakota. So she's doing virtual while the other one is in person. And that's a unique opportunity. But we also have an OT student that just started with me because she wants to start to build her business. So we've created kind of a unique fieldwork experience. And like David, I mean, could people create something like that right now with these students that are sitting there not able to graduate because they don't have a fieldwork placement anywhere?
Any of the OTs out there, if you could get yourself on the board of directors of a community mental health, and a lot of times they're desperate for people to be on their boards, then if you could donate 8 hours a week, or partner with somebody to do that, to provide the minimum hours of supervision that's required, to provide for level 2 placements for OT students, then you might get something going there. I just, maybe that's going to turn an organization around. Agencies love OT. I just met with, an OT program, and we met with an agency, and we're going to do that. Me and another OT are going to collaborate to provide the supervision. They are thrilled because they're always short-staffed. They just got all this money for COVID money that has to be used up by the end of the year, and they're looking for ways of reaching out to the community to provide mental health support services to the community. And they don't have the manpower. So we're going to provide that, and we're going to provide level 2 experiences, and those students are going to come up with something out there.
That's awesome. You'll have to keep us posted how all of that goes. That sounds amazing. Okay, we're getting close to being done, but Lisa posted on the Facebook, she said, perhaps community-based can look many different ways. Advocacy, health promotion, disease prevention, consulting, education. And I think I love that she added that on there. And one last question, if we can squeeze it in, is it's here somewhere. What do you think about training in ABA technique to incorporate in mental health services for OTs?
I think it's a terrible idea. Sorry.
I'm
Maybe,
with you, Dave. I am so with you. That's why I'm going to be quiet for a little bit, because no.
maybe I'm not totally well, maybe I do understand ABA. To me, OT is about an authentic relationship, a collaborative relationship with somebody. Yes, there is cognitive behavioral approaches where you're basically empowering the person to kind of identify triggers and things like that cause behaviors in themselves. But to do ABA on somebody is in such opposition to every single principle of recovery model, psychiatric rehabilitation, person's first approaches. And in my mind, it's, and somebody will yell at me, but you know, if you read our practice framework in the section on therapeutic use of self, it speaks of an authentic collaborative relationship that is authentic. So I'm not sure how you do ABA without having a collaborative partner relationship. Having a collaborative partner relationship, I don't see how it fits, but maybe I'm missing something and I should just be quiet. But
Well, just to do a real quick piggyback on what Dave was saying, there's really, when you're working with mental health, it's tapping into the passion and desires of an individual and empowering that. It's not about regulating behavior. It's not about managing symptoms. It's not about trying to control those kinds of things. It's really about how do we support an individual in capturing, in tapping into their passion. And in doing so, that then provides the energy and the ability to be successful in those meaningful activities while having symptoms. And there's a lot of things with like cognitive therapy, and there's a lot of stuff out there that just really talks about how do you access that passion, access that energy, and access that success. That's the direction that we really need to be going in. When you talk to a lot of peers talk about how they've been used by the system, or that they've been controlled by the system, or that treatment has been forced on them. And so there's a huge movement from the peer movement. It's really a civil rights movement about not being, nothing about us without us, about being at the table and being partners in the process versus subjects to be treated. So I think that it's really important to realize that if we're really going to be the occupational therapist, it's a matter of aligning ourselves with our clients and working with them in empowering the individual to access their passions and success. It's not about us pretending that we're almighty providers that have this great knowledge that we're going to bestow upon somebody, and then all of a sudden they're going to be better because we suddenly know and have this expertise that we're making them have. It's really about working with someone where they're able to access their own dreams and passions. And that might sound minor, but that philosophical difference is huge. And so I think that's a really important thing to have.
So that was awesome. I need to go back and write down exactly what you said, unless you just want to write it out and like we're going to put that on quotes and spread it out everywhere.
well, this is being recorded, so.
Yeah, that was very well said. Thank you. Thank you. Okay, well, it's an hour and a half, and it is late for all of you guys that are on the East Coast. So thank you for being here and doing this. We'll have to do a part 2 sometime if you guys are up for that. I know I've had, David, some people reach out if we're going to do a part 2 for the OTA panel. And we shared a lot of great information on this panel that all those OTAs need to learn about as well. So great info. Thank you guys. We will put together some of those resources that we talked about and send them out to those of you that registered for the webinar, but please reach out. Thank all of these amazing people that have given their time tonight to help educate all of us. So have a fabulous night. We'll talk to you all soon. Thank you.